I'm Carmen Masson. I'm a professor of psychiatry in the School of Medicine at UCSF. I also co-lead the I-STARR project with Amy Miracle, who's a research scientist in the alcohol research group at the Public Health Institute. The team also includes co-investigators Sarah Zemore, Lenny Jason, biostatisticians Mina Subaraman and Libo Lee, and communications specialist Diane Schmidt and Dustin Kesbo, and the team's project coordinator, Quinoja Kipitini. Next slide, please. So we are blessed in having a fabulous 17-member advisory board of diverse group leaders from across our country. And our advisory board members represent recovery and recovery housing leaders, treatment providers and payers, national policy advocates, and researchers and educators. In fact, you will be hearing from one of our advisory members today. Next slide, please. So with that, let me tell you about our presenters, Mr. Roland Lamb and Dr. David Pating. Mr. Lamb has been working in the field of alcohol and substance abuse dependence treatment for over 45 years as a counselor, therapist, supervisor, coordinator of addictive services, program director, trainer, lecturer, consultant, and administrator. And for the past 15 years, Mr. Lamb has been very involved in the development and implementation of behavioral health models. For over the past 20 years, he has played a significant role, formerly under the leadership of Arthur Evans and currently David T. Jones in Philadelphia's transformation to a recovery-oriented system of care. Mr. Lamb has many honors and is an adjunct professor at the University of the Sciences and Villanova University. Dr. David Pating is an addiction psychiatrist and medical director for San Francisco's behavioral health residential system of care. Since 2020, he oversees clinical care in San Francisco's mental health and substance use residential programs and the post-COVID expansion of behavioral health residential treatment and housing services for the county's unhoused community. Previously, he was chief of addiction medicine at Kaiser San Francisco and a former commissioner of California's Mental Health Services Oversight and Accountability Commission and the San Francisco Health Commission. Dr. Pating is an associate clinical professor at UCSF and has received numerous awards for his coalition leadership to advance behavioral health care as an essential insurance benefit under Covered California's implementation of the Affordable Care Act. So without further delay, let's turn the presentation over to Mr. Roland Lamb and Dr. David Pating. Thank you.
Well, I want to say good afternoon and good morning. I'm on the East Coast, so good afternoon. And for those of you on the West Coast, good morning. I am going to see if I can't get through my presentation in a short amount of time, but as you can, let's go to the next slide. You'll see that it's kind of ambitious in terms of what I'm hoping to get across to everyone here today. So let's get started. I'll go to the next slide. Recovery residences and a transforming or recovery oriented system of care, both predate in terms of their origins, the actual development of a recovery oriented system of care. By generation, the first generation of transformation began with the deinstitutionalization of psychiatric hospitals and asylums in Philadelphia, and worked towards the idea of bringing people back from those hospitals and putting them in the community. And so you had the creation of CLAs or community living arrangements, long-term living arrangements. You had outpatient community clinics and base service units that were all created in order to move this population back into the community with enough supports to be able to exist in the community and thrive in the community. Go to the next slide. At the same time, we have a movement in Philadelphia that began with the crack epidemic. And it actually signaled the beginning in the late 80s and the 90s, a focus on transforming, not only transforming the mental health system, but also the substance use system of care. And we began to look at the idea of community recovery, and the idea that we were going to be moving from communities that were being overwhelmed by crack to communities that were now going to have a voice. And they actually had protests in the street. They would go and close down, and shutter crack houses. And in the process, the city began to see the benefit of taking those, confiscating those crack houses and donating them to the communities and people of lived experience to be able to create recovery houses. Next slide. And that opened up a whole range of opportunities for people to create the recovery house system. We had the Oxford houses already in Philadelphia at the time, but the idea of these recovery houses were almost like an indigenous support system that was created. And these were also an opportunity for people to ID, i.e., make money. And we had some very unscrupulous people at the time in Philadelphia who also got into the recovery house business. And they made it something that was not, there was somewhat unscrupulous at the time. It was taking advantage of people who were struggling with their addiction in terms of their Medicaid and Medicare, and putting people to work, illegitimately or inappropriately, illegally. And we had to begin to crack down. There were over 300 entities in Philadelphia that we saw that were recovery, they identified themselves as recovery houses. And because there was no regulating at that time outside of the couple of recovery houses that were in our system, there was, it was pretty, it was pretty wild. It was pretty, uh, unfocused and unregulated. Next slide. So we go to the second generation in Philadelphia, because we go from deinstitutionalization to now liberation. We're liberating the traditional system of care and creating another system of care. And to do that, we began by creating, the first municipality, run and owned managed care organization, and that's community behavioral health. And that allowed us to be able to manage all of the grant funding, as well as Medicaid dollars that came into Philadelphia for behavioral health care. It also allowed us to begin to break down the walls of a mental health system versus a substance use system. And you'll see the reason for that later. But the idea was that we were able now to create a very different kind of system of payment for these services. And this began in the late 90s. Next slide. So we became a city government partner with a 501c3. We managed all the public sector behavioral health and intellectual disability services. And through a collective management of federal, state grant dollars in conjunction with Medicaid dollars, we were able to put together a very different system of care. Next slide. And the reason we needed to do this is because we had Philadelphia had the highest percentage of people in this population. We have a city of 1.332 million people in 2002, 2004. And we had the highest percentage of people on Medicaid, of any large city in the country. And the idea is that when you take a look at these graphs, you'll see that we had a large number of people who were identified with a mental health diagnosis, and then you had a number of people with a substance use diagnosis, and you had a number of people who had a combined substance use and mental health diagnosis. But when you take a look at what we were spending, the dollars that we were expending, you can see that we were spending a great deal of dollars in terms of mental health, less dollars in terms of substance use, but huge amount, most of the spending went into managing the people with a co-occurring disorder, substance use and addiction. We also had another problem, and we had overcrowding of our prison system. Philadelphia, from the beginning of from the mid 90s on, was under a federal court order because it had a prison system that had a capacity of 5,800 people that was housing over 9,000 people. And we were actually, managing much of our addiction services through our prison system. And then last but not least, our traditional system of care was stigma driven, as well as it was an acute care provider focused and acute care system. Next slide. When a system, is like that, then we're talking about a system that has an umbrella of services that are often fragmented and hard to access. And by the way, it's only defined by levels of care. In many ways, we need to see people as being, we see people in a broken system as being broken themselves. And we only see the drug use and not the person. The idea is that we are managing through a stigma, the lens of stigma. And we neglect the needs and safe housing, and i.e. safe housing and wellness and life skills. Next slide. We do a great job at getting people into treatment and addressing the acuity of the emergency, emergent care. But with the idea is that we need to have a system that is that maintains people in recovery, a system that has supports that can address what's next, a community that has community education and training integrated into recovery, to develop networks of supports, nested in recovery, and become bridges of long-term recovery, for where those seeking who are in recovery are. Next slide. So we're looking at the idea of a traditional system of care, because I said before, is stigma-driven, is based upon a provider-centered model, and it's acute care driven. And one of the things that we have to begin to be careful about is the fact that there are disconnects between long-term recovery, individual and family community, physical and behavioral health care, self-help and professional services, traditional and peer supports. Next slide. Now we're in our third generation, and we're in our third generation. Dr. Arthur C. Evans comes to Philadelphia and brings ROSC, or Recovery Oriented System of Care. And you can see here, the characteristics of a ROSC. The two most important that I want to point out, during this is it is person-driven, and that emerges from hope. And the idea is that this ROSC system, you go to the next slide, is best defined by the words of Bill White. And let you guys just read this quickly. So we are attempting to do something very, very different than the traditional systems of care. Next slide. As you can see here, this is the first definition of recovery that our system developed with people who are in recovery, people who've lived experience, providers in our system, as well as the folks managing the system itself. And this was the initial idea is that recovery is the umbrella under which everything fits. No longer looking at recovery as opposed to treatment, or recovery as opposed to prevention, or recovery as opposed to anything. Recovery is the overall umbrella, and under that umbrella, you have all these different aspects of people getting better. Next slide. And we propose to take that umbrella and give it to the people who need it, and make it available for them to use as they need it, as opposed to deciding for them how they are to use it. Next slide. We want to also identify the fact that the key ingredients to a recovery-oriented system of care are recovery vision and values, high-performing collaborations, strong community linkages, targeted recovery-focused interventions, integrated behavioral health services, committed transformation champions. These are the 6 ingredients that become most important developing a ROSC. So now we move back to recovery houses. And now recovery houses have a different bent. Next slide. We have a different view of recovery houses. Now we're looking to, the recovery houses from the standpoint that they're assets now in our system. And we now need to invest to increase in them to increase their effectiveness. These recovery houses are physical plants that have to project hope, because that's what recovery is about. The hope that people begin to feel, in their recovery, they're overcoming their challenges. Next slide. As well as reevaluating the buildings, we also had to ask the question, what kinds of services are going on, in a recovery house programs. And we need to be able to address that, as far as, the recovery people is concerned. Next slide. That recovery houses need to be involved in the community. They don't need to be black boxes in the community, i.e., where they just exist waiting for somebody to use them. They need to be, have a presence in the community. Next slide. This is our second definition of recovery that the system came up with. And I just want to point out the last part where we say that, do we only recognize the state of recovery, or do we acknowledge the struggle of those to overcome the challenges of people, places, and things that ultimately lead to the neurobiological condition we call addiction? Is there a place before the state of recovery that we outreach, engage, and enlist for recovery? And that actually takes us to, to the idea that recovery houses actually, have a role that begins before people can, or even acknowledge that they are in recovery, and that somebody can be still using and whatnot, and but still, be helped along, to come into recovery. Next slide. To that end, we developed the transformation guidelines, and there are directions in the I think the chat for you to be able to access these materials. Next slide. We reached out to the National Alliance for Recovery Residences to create, to take a look at international standards, national standards, and begin and to address raising up recovery houses to a certain level. Next slide. We used a tier model and integrated those national standards into a tier model. Next slide. We were refocusing recovery houses programmatically. We actually began regular site visits. We began to integrate recovery houses into our treatment system. And you got to be very careful now, because now you're getting into changing recovery houses from the indigenous organizations that they began as, and to become more and more like the system that we were. And we needed to be careful about not taking away what made them important and what made them work for us. Next slide. So we need to be involved in the hiring process, which is also, as I said before, which is also very crucial, but also very dangerous, because if you get into another entity now that now is involved in the hiring of people in the recovery houses. Our staff, we got into staffing ratios. We now require that recovery houses had to have, a mix of people, of peers, and people who were working in the recovery houses to the number of people that were being managed in the recovery house. Next slide. So we began to refocus recovery housing operationally. We created standards and staff structure, and as I said earlier, staff ratios. Next slide. Because we were building, so much up in terms of a staff, we created an opportunity for people now to have jobs as peers. We developed a peer toolkit. We worked with people of lived experience, peers, and a consulting, HR consulting, to come up with an interactive tool that allowed providers to be able to hire peers, and work with peers across our system, and especially in recovery housing. Next slide. We were focusing recovery house training to develop, harm reduction series, because it became very important that we were not going to pay recovery houses for excluding people, but they had to be inclusive of the folks that they were seeing. So that included people on methadone. And that became a big issue as far as helping, staffs in recovery houses to understand that methadone, did constitute recovery. Next slide. The planning, we had to begin to talk about, the idea of going federal grants. And I want to give a shout out to Amy Miracle, because there was a time when Amy was working with us in Philadelphia and helped us to develop our programming, as far as going after grants and looking at opportunities to include recovery houses in and doing research. We also advocated with the state so we could increase the length of time for we could pay for recovery house beds at that time. Next slide. The fourth generation that we're now talking about, it includes population health and system integration, or achieving systemness. And the idea that is that we had to also identify the fact that there were disparities in our treatment system because of a lot of different reasons, including stigmatization. There were education, there was education, regional, educational, racial segregation, social supports, and poverty that accounted for over 1/3 of the total deaths in the United States in a year. They were very prevalent in Philadelphia, and we needed to address them as far as, on a population health basis. And next slide. So we reached out and began to develop communities of care. And they actually included recovery houses at both the front end, the middle, and the back end of that care. So that means that people who were entering into our system, people who were being treated in our system, and people who were completing our system had access to recovery housing. Next slide. We encourage recovery houses to become halfway houses if they could. At the same time, we were developing staff to become more and more involved as far as and educated. We developed, education around developing recovery houses and actually going after being licensed as halfway houses. We also created a halfway house association, which allowed our halfway houses to go together and compare notes. Next slide. The state eventually, began to get involved with the recovery house system because they, were looking to find out ways to create standards for recovery houses, because we were using state dollars at that time to fund recovery houses. And so the state got involved. We got involved with the state and created with recovery house regulations. Next slide. You can see now we are now looking at a network that is very developed. We have over 900 residential beds, but even more importantly, we now have, as of this year, I think, over 500 recovery house beds. Next slide. Recovery houses became the linchpin for our system during COVID. We were able to bring people into our system and make sure that folks got access to care. Despite the fact that the big concern or the big issue during that time was we also put recovery houses, in the crosshairs, so to speak, because it became ground zero where people can, becoming infected with COVID. And we had, we were very much involved in getting people into the hospital, into treatment but that also got infected when they came into recovery house. Next slide. That being said, recovery house staff and recovery house constituents, it became a part of our peer culture and recovery house community efforts, so that we began to have we had a same day pay, same day work program. Recovery house participants participated in remote recovery support, isolation and quarantine sites, peer support, the Kensington storefront, and recovery advocates serving in the community, recovery awareness events, storytelling training, and liaison to community support programs, all occurring, with recovery houses. Next slide. Recovery houses have become so involved in Philadelphia that Philadelphia has now developed what is called the Riverview Wellness Village. It's a program, it's really a mall of services established in conjunction with recovery housing. And it's designed to have access to health care, primary care, for substance use and mental illness, education, and workforce development. And so this opened up, in January this year, and it's over 300, an additional 336 beds that are now available as a recovery house system. Next slide. So what are the obstacles that we face now and for the future? There are obstacles of regulations, stigma, cost, workforce, and siloed services. And the idea of getting beyond and creating addressing this indigenous service delivery, is very, very important in terms of the balance that you create between the programming, and the system. So, the idea of creating systemness. So, on that note, I am going to go next slide. I am going to stop here and turn it over to David, and then we come back and talk to you all later on.
Hi, good morning or good afternoon, everyone. I just want to thank Roland for a wonderful presentation and sharing the long chronology of getting to where you're at. I mean, you definitely are an expert in terms of been there, done that. And I think there's a lot to learn from trying different models of care and seeing what works and refining things over time. I'm going to take a little bit of different approach and kind of talk about different ways. I think just touch upon what Roland had talked about how San Francisco, we've in a very short time had to consider different ways as we've moved through our recent overdose epidemic. Next slide, please. So during COVID, we saw in San Francisco a preponderance, an expansion of individuals who were unhoused and a drastic rise in the number of overdoses, mostly fentanyl, but also methamphetamine, that we had witnessed in the city, such that during the height of COVID, we had over 700 or so overdoses within a year, the highest that we've had, and we're only a population of about 850,000. Um, so you see here this rising curve. It started all the way back with the OxyContin and then heroin explosion, but really took off during COVID. And much of our city's effort has been taming this wild beast. We're making some progress, as you can see in the upper box. The last couple of, this is a monthly chart, last couple of months have been trending down, but it's still a long way to go. When we look at where overdoses are occurring in San Francisco, we see that the purple dots here are the addresses of overdoses, and about 23% of our overdoses had no fixed address, meaning they were unhoused, and a very large percentage of overdose occurred in single residency occupancy hotels, so people that were precariously housed. And so I'm going to speak to you what we've done from a recovery and recovery residence perspective to try to deal with this because, as you know, receiving drug services while you're on the street is very hard to do. So a lot of our residents and treatment programs have been trying to build housing or treatment-based programs that are residential. Next slide, please. So our strategies in the city, and this has been directed by our highest level of government, our mayor, and even our state supervisors from our local area had gotten involved in designing our strategies. And it was very simple. One, we either get you into treatment if you're at risk for overdose or using and unhoused, and we get you into treatment now. In that treatment, we want to have, like Roland discussed, a robust continuum, basically everything you need under one roof. And we want a path to functional recovery, which means at the end of this, you'll be able to live on your own and have a sustainable lifestyle. And we want to maximize our state Medicaid funding for this. Our other strategy was, well, let's just get you off the street. This is more of a housing first approach. Let's get you into shelter. When? Now. And then let's wrap all the robust services that we can so you stay in shelter. Of course, that includes substance use services and make this a path to permanent housing. And of course, maximizing housing funding. And in many ways, these are the same things, just different places and different destinations and starting points. Next slide, please. So we have a lot of residential treatment in our city. We're one of the better funded cities in terms of receiving local dollars, plus mixing them with our Medicaid dollars, probably Los Angeles County, um, us, Orange County, um, Santa Clara County. These are probably the counties with the largest number of residential services. We have 58 withdrawal management beds. I put dollar signs because these are very expensive. They often involve medical services, 5 to 7 days. And they're high demand because they are the front door for our persons that are experiencing homelessness. Um, Many of our residential programs feel that people need just a few days of simmering down or starting opiate treatment in withdrawal management before moving on to what is our traditional residential treatment. And our programs in our licensed residential Medicaid eligible programs, we follow in our state ASAM criteria. So withdrawal management would be 3.2, residential treatment would be 3.1 and 3.5 ASAM designations. These are 60 to 90-day programs. They offer individual and group counseling in a residential setting, and they're participatory. And they require pre-authorization or authorization. And again, these are all licensed and state regulated programs. Then lastly, following the 90 days, we've developed a whole set of programs that are funded by block grants, but are not necessarily as licensed or regulated. And these are residential step down, or what you might know as traditional transitional housing. But this transitional housing, because it involves state and local funds, we require it be linked to licensed outpatient treatment. So you're getting pretty typical ASAM, continuum from withdrawal management to ASAM residential care to then a long-term care, which is really housing plus a step down to outpatient. And there's many strengths and challenges of this system. One, it is state regulated, which is good. We have good quality, but it is relatively expensive because you have licensed staff here, licensed clinicians, and you have to follow a lot of regulations regarding the setup and standards of the actual facilities. They are structured. That is also difficult for populations that are particularly unhoused, because if you've been unhoused for a year or two, telling your house um, uh, parent or director that you need to be cleaning the bathrooms, and oh, by the way, you have kitchen duty this week, often doesn't go well, and people may leave rather quickly. However, related to that, they can be safer because they're congregate as opposed to being in other shelters, which might be more single occupancy. And unfortunately, if you're coming off the street, most people do prefer to be alone in single occupancy kinds of residences rather than congregate settings. But the congregate settings, as you saw, that when I reported that where our overdoses are occurring, are safer. And we always need more, but it does take 6 months to a year to get a program up, regulated, costed out, and licensed to the standards that we would like. So during our opiate crisis, next slide, and overdose crisis, we began to look at the other side, which is really looking at the housing and supportive housing continuum. And we have a history of an extensive housing network. We have over 3,000 housing beds and 600 or 700 permanent supportive or transitional housing beds. But we took the opportunity during this crisis to develop new city sponsored, because these were not state funded, respite centers, which were sobering centers, stabilization hotels, which are short term, 30-day single residency occupant hotels. They're limited to 30 days because in our state, if you're staying in a hotel over 30 days, you get tenancy rights, and so then you can't be evicted. And so these are meant to be accessible for people coming off the street. And then we have transitional residential recovery, which I'll share with you. This is, I think, the traditional focus of residential recovery, as you might find through the National Association of Recovery Residences or SAMHSA models. And these go for 90 days to 2 years. And the nice thing is the cost of these programs, because they're primarily housing with other services that you can bring in, is much less than the treatment. And to make them better and to do kind of what Roland's mission, which is to make them more comprehensive, we can bring in outpatient services, which do receive Medicaid funding. And these can include medications for opiate use, addictions, methadone, and buprenorphine. We can bring in medical services. We can do case management and linkage. And we can do contingency management, which in our state is also Medicaid funded. And we can focus them on many goals, which include abstinence, harm reduction, or just even getting people started in treatment, starting at a hotel, getting them some respite, and then moving on to the next level. So we're finding a lot of use out of this supportive housing. It's quicker, it's faster, it's cheaper, but we have to make sure that we don't trigger. If some of these programs, if you build them in a certain way, you're actually fall into a licensing box. So it's a very thin line sometimes that we have to tread to be fast versus being highly regulated. Next slide, please. So some examples of the programs are this Summarize program is a 23-hour drug sobering respite care. It's a day shelter. You can stay up to 23 hours. It's 23 hours because our fire department says that you stay more than that, then it's an occupancy and you have to go through a whole level of fire certification. So less than 23 hours, you're just a day shelter. I can overnight you there, and then the next morning, we'll get you on your way. And what we say here, it's better to have a crisis indoors than a crisis out of doors, where police might pick you up for walking in the street, yelling at a tourist, and other reasons that people get picked up for substance intoxication. Built on a shelter, did not require licensing. We have to do a lot of overdose prevention because people do bring in drugs. But this is another example of using housing or shelter model for a wonderful entryway. And this program often is an entryway into treatment. Once people get their respite and the overnight sleep, they are much better to decide what to do in the morning. We also use this short stay model, more hotels though, for starting people on buprenorphine. During our overdose epidemic, we had large congregations, up to 1,000 people, where they would gather in some of our open areas, selling, buying, using, having parties, music, eating candy, because candy post intoxication is what people crave. And we would have night navigators go out with iPads and try to get people on buprenorphine and say basically, hey, look, I can get you some housing tonight. Would you like housing? But if you, and getting on buprenorphine. And we have a very high uptake of this very short-term stabilization housing linked to buprenorphine care. And this is a nice induction or initiation pathway, and very low cost hotels, less than, I think they've been like $12.50 a month for the hotel rooms, less than $70 a night, plus buprenorphine, and very high uptake in terms of initiation. The Armina project is a standard residential recovery type 3 program, but we've had to apply it for those that are post-treatment, like post either withdrawal management or post that initial 30 to 60 days. Because if we did this type 3 residential recovery program for people that were initiating treatment, we would be actually creating a licensed program in our state and be triggering a lot of red flags. But the nice thing we've been able to do with this model in the city, we've taken a lot of unused tourist hotels. We've been down about 30% in terms of tourist visits, and we've taken these hotels and converted them to residences with conditional use permits. And we've wrapped around some nurse practitioners and other psychiatric care. And this MINA project in particular is a dually diagnosed program, particularly for those coming out of jail. And we've been able to tailor make these programs, stand them up quickly, relatively cheaply to target special populations. African Americans coming out of jail. We have some Spanish speaking ones and a program for women and children that we are able to focus. So we're able to focus on and micro target these recovery residences in a way that's been really wonderful, as well as take excess hotel space off the market. And then lastly, moving in the more permanent direction, we have a managed alcohol program. This is after a Toronto model where people actually get prescribed alcohol on site and monitored for their alcohol consumption and voluntary groups, but all as a condition of being in permanent supportive housing, that they would not go into a bar or a liquor store. We've had really great results in this. These are people that have been chronic inebriates in our city and picked up with 200 ambulance calls a year. And within 6 months, they have been actually transitioned to drinking almost at a less than a half a bottle level after coming in with 2 pints a day, or and many transitioning to a real non-structured, regular permanent supportive housing. So the benefits of these kind of examples, and these are just examples, is we're finding using housing, both state and local funds, we're able to get these programs up and running with rapid access to shelter. We're transforming our hotel stock and they're less expensive. We're able to integrate outpatient services, which are Medicaid refundable in our city. And while clients often prefer non-congregate settings, that is a difficulty. Our residential recovery program is both congregate, and because they're hotels, we were able to take single room hotel rooms, take the door locks off, and create basically a congregate setting with everybody getting their own room, like in a college dorm, and blend and braid the benefits of both. But still, being alone and using is the highest risk of overdose. Next slide. So my takeaways to you, I mean, all the lessons to learn are from Roland, but the lesson that we're learning in our city is to be as creative as possible with and maximize the funding that we have. We have a really large national problem with overdose and substance use, and we just need to get people off the street as quickly as possible. And that's where we're focused with both arms of our services, either treatment, Medicaid, ASAM, insurance-based, or housing and community-based programming. So I'll turn it over to Amy for discussion, but I hope to talk with you more on
Wow,
different options.
amazing presentations, both David and Roland. And Roland, I appreciate the shout out, but I have to turn it right back to you because I learned about recovery housing from you while I was living in Philadelphia doing treatment research. I love the chronology. I was only part of the third wave, and I feel really lucky to be part of that story. So Carmen, I think in the interest of time, we were thinking that we would do some discussion between Roland and David, and then do audience Q&A. But again, in the interest of time, let's just cut to the audience Q&A. We haven't fielded any questions in the chat. Feel free to drop your questions for Roland and David into the chat, or at this point, just unmute yourselves. Carmen and I do have some questions for both David and Roland that we can lead things off with, though. Carmen, do you want to take it away?
So thank you so much. Thank you both for that excellent presentation. So at this point, as Amy said, we want to give everybody a chance to ask questions. So don't be shy if you have any questions about any of these fabulous programs that Dr. Pading spoke about in San Francisco, which are, I think, very progressive. We'd love to hear from you.
But I'm sure Amy is familiar. I'll jump in. I always have questions. I wanted to know, Roland, you talked a little bit about the that kind of interface between, kind of the structural level of trying to make sure that all the services are working kind of as planned and like fitting within the overall system. But then the tension between that and the actual individual providers or like the house directors or owners or managers and stuff like that, and how there can be that tension between like, I've worked in some collective impact models, right? And one of the biggest things is the individual organizations along the continuum are like, what are you going to tell us how to do our job? Are you crazy? We've been doing this for 50 years. How are you going to come in and tell me how to do this thing? So if you could talk a little bit about kind of managing that side of things, which I'm sure it's tricky.
Well, we really have to be careful about the idea of if you want me to pay you, you have to do it this way, and or you have to do it that way. I think that part of the issue is that we lose sight of the importance of the indigenous approach. When people have gotten together without a system of care or overseeing them, and had some success in terms of creating a safe environment or a consistent environment for people who are struggling, we have to make them over again in our image. And that has to do with regulations. It has to do with policies and the like. And we really need to be careful about that. We really need to understand that we're working with people. And that's why I keep telling our system needed to stop chasing the drugs and start chasing the people, identifying with folks where they were at, and being very conscious of developing programs that supported them where they were at and how they could be best served. That's why the idea of the umbrella and giving that umbrella to people who are in service or excuse me, who are receiving services is important.
And I like that too. And that was one thing I noticed is it seems like those, indigenous services and indigenous organizations that kind of grew organically out of, in Philadelphia, seems like they, and just the point of like not losing that sort of secret sauce, right? That magic, right? It came out of this specific culture. We don't want to like, we don't want to like, we want to keep that, right? And it seems like how much were they involved in forming the process for the, it seems like they were involved for the overall system of care, maybe so that they had buy-in, they had a say in like how the system of care was developed over time, so that I don't know, was that part of the process? Did I miss it?
It's very difficult to stick with a peer driven agenda. And the reason why is because like the traditional treatment system, the question of who's in charge always comes up. It's I always tell people that in my mind the most insidious of all addictions is the addiction to power, and it's also the greatest illusion. And we come into when a city becomes or a state or a federal government, comes face to face with things like recovery houses or sweat lodges or biofeedback. The issue is that oftentimes it says we can't do it unless we do it this way or we do it that way, or we have a professional person who is doing it. Somebody who has a college degree or has an advanced degree. We have to begin to understand that folks who are not always connecting on that kind of level in that kind of way. And are we ready to work with people who are not willing to, for instance, who are not willing to stop using? But the idea is, how do we connect with them, and how do we begin to bring them into our system and begin to work with them in the kind of way that allows them to manage their own recovery?
Mm-hmm. Thank you so much.
In San Francisco, we try to look at this more of at a system level. We have a lot of agencies that represent kind of our micro communities. We have an Indian Health Service, we have African American agencies, we have Spanish, Latinos, bicultural, bilingual agencies, women's programs, perinatal programs, and also realizing jail is its own. Those that would have previous incarceration history had their own um, acculturation. If you've been in jail for 20 years and coming out of prison, you're used to structure, right? Waking up at 6, getting to the breakfast, getting to the courtyard, back in your cell at 12, and so forth. But that's also very different from our unhoused population. You've been unhoused for 2 years, you just could be anywhere, right? And so we've tried to engage providers that are part of these communities, kind of participatory, like you would participatory research. This is like participatory treatment, but we've not tried to micromanage how they manage the cultural elements of their program. We say, you know what, you guys are the experts. We're providing you the funding to be the experts, but what we do monitor are two things, really. One is the organizational fidelity to certain standards, right? If somebody dies, how do you research that in your program? And what are your policies about somebody relapsing? And if somebody doesn't like what you do you have complaint processes? So to assume kind of like what would be good healthcare within these models. And then secondly, measuring them on really the most important indicator for all of our programs, which is retention. If people leave, that's a negative outcome. But like AA says, keep coming back. Same thing with residential treatment. The best indicator of outcomes from a NIDA perspective is retention and care. So if you stay there 2 years and your client's 2 years, and I'm going to assume, and they can get at the end housing, employed, or engaged in education. I can't wish for anything more than that. But this is where it's a real partnership with these community programs. It makes it kind of like flabbergasting because not all communities can operate at the level that we want them to be, I guess medical organizations could wear city running as a health department. But we try to build competency, support their strengths, or support their weaknesses, and let them run with their strengths. And that's the goal. Doesn't always work that way, but that's the goal.
Well, that's wonderful. So I really hate to cut off this discussion. And it's been really great, but I think we're going to move on and tell you about what's happening in the next couple of months. I don't know if we have slides, Quinoja. Okay. So next month's webinar is going to feature our own Patrick Hibbard. We'll be presenting on the state of recovery housing literature. And in August, we'll hear from another member of the I-STARR Advisory Board. We'll hear from Ninh Nguyen Ngo, who will be presenting on the topic of integrating recovery housing and substance use treatment. The I-STARR webinars are held on the third Tuesday of the month from 11 to 12 for those on the West Coast, which is 2 to 3 for individuals who are on the East Coast. And you can register for any or all of the webinars that we have scheduled on the I-STARR website. And you can also stay connected with the I-STARR project through our social media accounts, which are listed on the slide. So while you are on the I-STARR website, you may also see information about the I-STARR training series. And the I-STARR training series consists of 12 webinars with separate topics for recovery housing operators or providers, as well as for those interested in conducting research on recovery residences. So those participating in the 12 webinars in the training series will receive a certificate of completion and be provided the option of being identified on the I-STARR website as someone who's completed the training. So at this point, because the live webinar series has ended, we only track completion of the webinars if you register for the series and view the webinars on the I-STARR Learning Management System on the website. If you have any questions about the training series or about how to complete it, please contact us. So we are running out of time and it's hard to stop, but I want to thank again our presenters, Mr. Roland Lamb, Dr. David Pating, for an amazing webinar, and everyone for their attendance and their time and attention. We hope to see everyone again on Tuesday, July 15th. Enjoy the rest of the